and welcome to today's webinar, the Medical Respite Care Programs and the Triple Aim Framework for Health. My name is Barbara DiPietro, and I'm the Senior Policy Director with the Council. I'll be acting as moderator for today's discussion. I really want to thank everybody for coming today. I know everyone's time is valuable, but there's really exciting work being done in medical respite programs in the country, and this is a really great opportunity to talk about that work. In fact, we originally thought that we could do this discussion in about an hour, and we quickly realized there's just too much to talk about, and so that's why we changed it to a 90-minute discussion. So again, really appreciate your time in joining us. We wanted to have a richer discussion today about the changing landscape in healthcare broadly, and then how medical respite programs can strengthen their role in all of that work by aligning their outcome measures with the larger systems in their communities who generally have more resources and have the most decision-making power. So one of the things that we just want to make sure we see here is that this webinar is supported through a cooperative agreement with the Health Resources and Services Administration at HHS. Yes, this session is being recorded, and yes, the recording will be available on our website along with the slides, and the slides have also been loaded in the resources box at the bottom of the screen here called Webinar Slides, so you have access to that. And even better, if you have registered for this webinar, you will get an email directly with the link to all the materials. So let's move on and just talk about the great lineup of speakers that we have today. These folks have been putting a lot of work into their programs so that they can get more rigor in their data and have outcome measures that really support the value that they add to their community systems. And so just want to start off by introducing Rhonda Hoff, who's the Chief Operating Officer and Deputy CEO at Yakima Neighborhood Health Services in Yakima, Washington. Then we'll hear from Dr. David Munson, who is the Medical Director at the Barbara McGinnis House in Boston. And then together presenting, we've got Jessica Savara, who is a social worker and a recuperative care program supervisor at Central City Concern, and her colleague, Jordan Wilhelms, who is the complex care program manager also at Central City Concern in Portland. So we're really excited to be joined by these experts in this work. We have planned to reserve time at the end for questions and answers. A lot of our presentation today is going to be a panel discussion with the four folks you see here. So it may be that your question gets answered as we're engaging in the discussion. But below the presentation slide, you'll see that there's a chat box for your participant questions and any technical issues that you might be having. So if you want to type your questions or put your issues into that chat box at any time, we'll definitely either get back to you directly on your technical issues, and we'll get to as many questions as we can at the end. So here's how we wanted to spend our time today. First, we will just hear from our participants, talking just briefly about their programs, what they look like, and what performance measures they're currently collecting. Then I'm going to just do a really quick overview of the policy brief that we've just published along this line. And again, you will see in the resources box below the slide what's called policy brief. Is the short document that we put together that supports this discussion in aligning the Triple Aim framework with medical respite programs. Finally, we'll have a panel discussion with our program experts, and then we'll go to some audience question and answer. So that's how we will spend our time. And then here's what we're hoping that you take away from our discussion today. Three things. We want you to be conversant on what the Triple Aim is and its three components. We want you to be able to name at least 5 outcome measures that are good for medical respite programs. And we're really hoping that you take away some options for how you can align your respite program with the larger healthcare community's interest where you're working and make that really relevant for you. I just feel like this is such an exciting time for medical respite programs in general. There's a solid understanding throughout the entire medical system that the lack of housing and other social determinants of health are undermining the medical care that they are delivering. And so everyone's looking for answers and everyone's looking to get better. So this is a really good time to really emphasize the relevance and the value of medical respite. So I think we have an interest in getting greater recognition for medical respite programs. We have an interest in gaining more sustainable funding for our medical respite programs. But at the same time, that also means that we have to be responsible for demonstrating that our programs work well. And so what that means for us is having the right kind of data and doing so in a way that aligns our interests with the interests of our bigger partners in our communities. So I think that there's an interest here that we have, but it also means that we have to get more rigorous in what we're doing as well. And so with that introduction, I will turn it over to my colleagues to briefly describe their programs and the measures they're collecting. And I will start with Rhonda Hoff and her program in Yakima. So Rhonda, take it away.
Okay, thank you, Barbara. So as Barbara said, I'm Rhonda Hoff from Yakima, Washington. And Yakima Neighborhood Health Services is a community health center. We have 9 primary care sites in the Yakima Valley. And in addition to our medical respite program, we also have 80 units of supportive housing. And if you don't know anything about Yakima, we're a town of about 100,000 people, and the county is about 240,000 people. Yakima itself has about 100,000, but the rest of the county is really very rural. And so our concentration of homeless services and individuals experiencing homelessness is really primarily in the city of Yakima. So our respite program operates from 6 individual 1-bedroom apartments. Sometimes we double them up to address the capacity issues. Our medical staff are on site daily, but they're not there 24/7. And because of this, patients need to be fairly independent, capable of getting themselves to and from their beds and the bathroom, and able to put meals in a microwave, and we provide the meals. We are not a licensed facility, so they also need to be able to manage their own medications. And next month, we're opening another program, another respite program with 5 more beds, and this model will have 24/7 oversight, and we'll see whether this makes a difference in our program outcomes in this model. We expanded because last year we served 70 individuals, but we also had to turn away almost 40 because of our capacity issues. So what you see on the screen here is our eligibility criteria. And we have homeless here first because we get quite a few requests from the community to take patients who are not homeless. We have people who live alone and who need help, so we emphasize that the first criteria is that they need to be homeless. Our outreach nurse performs the intake to evaluate our ability to accept patients into our respite programs. Sometimes there's a lot of pressure from hospital discharge workers and others to take patients with a higher acuity than we can actually manage. So our intake form is also the referral form that comes from the hospital and the discharge workers. We designed it, but it has our eligibility criteria on it. Our respite program is a block away from our primary care clinic, and the respite staff are responsible for the respite admission, as I referred to earlier, from the primary care provider, the hospital, or the skilled nursing facility. These are all places where our referrals come from. And our respite team provides the daily oversight and the health education, and really they help with the connections between the patient and the community. So the respite staff bring in behavioral health, the housing case managers, the insurance navigators if needed, and they help the patient get to whatever services are appropriate, and most of which start with the primary care provider. And then we rely on the PCP, or the primary care provider, to tell us when the patient is safe to be discharged from the respite program. Once the discharge occurs, then oftentimes we'll continue the case management with the patient, even if the discharge happens back to the street or to the shelter. So you can see here again on the screen, this kind of talks about the division of responsibility between the respite program and our community health center. And again, those are both programs of our organization. So the coordination is pretty seamless. When we started our program just a little over 10 years ago, most of our referrals, as you can see here, came from the hospital discharge planners. We were taking patients from inpatient care, and our goal was to keep them from being readmitted. But as time went by, and as our primary care providers became more understanding, more trustful, and just had a better understanding of what the staff could do, the pattern really changed. The primary care providers are sending more patients to the respite program as an alternative to sending them to the hospital in the first place. So we're preventing admissions as well as readmissions. Last year also, about 13% of our referrals came from same-day surgery centers. In fact, the same-day surgery centers often call our staff and schedule the surgeries based on the availability of the respite beds. So one of our first outcomes when we first started our program was really targeting on reducing the admissions of our patients experiencing homelessness, as well as the number of readmissions of those patients once we've got them into the respite program. So in addition to providing, as I mentioned, in addition to providing medical respite care, we're also a provider of permanent supportive housing. And as a community health center, we wanted to compare the health status of our patients in respite and in supportive housing to our general health center population. We have a lot of data, and as a community health center, we collect a lot of clinical data for the UDS or the Universal Data Set measures. So we saw these outcomes that are tied to the triple aim as being directly related to the efforts that we were working on to improve the health status of our special populations. And Washington State being a very highly Medicaid managed care state, we're really looking toward all of those patients and many of these patients who are covered now under Medicaid, really being able to look at the outcomes that are also tied to our new pay-for-performance contracts in the Medicaid program. So these are some of the examples of things that we measure now, and again, these also are related to not only pay for performance, but our access to care and our UDS measures. So tying back to the triple aim. So the slide on the left here, the picture on the left rather, shows our access to health coverage measures. So the slide on the left shows the far left bar rather shows about 24,000 unduplicated patients. 73% of our general health center population have some form of health coverage. And 85%, the next bar, is our total homeless population, which is about 85% of them have health coverage. And then we look specifically at our patients in supportive housing and our patients in medical respite. So 77% of our folks in supportive housing have health coverage, and 89% of our patients in medical respite have health coverage. Not all of them had coverage when they came into our programs, but our insurance navigators can go to the folks in housing or in respite to help them sign up for coverage. So we feel good about that. The bar on the right shows that our patients in medical respite have the highest average number of contacts. Our average length of stay in medical respite is just under 20 days, yet have the very highest number of average contacts. So that's largely due to the amount of time they spend with the case managers, with behavioral health, with their nursing visits. So that's a combination of all of those case management visits, and sometimes even dental, depending on the patient. And then supportive housing average length of stay is well over a year. So it's a longer period of time, and a particular niche in the community is serving primarily chronically homeless in our housing. So these folks are frequent users in our clinic and our case management services as well. So you can see here our average contacts per user was 41 for respite and 35 in supportive housing compared to our general populations above. And then another way to look at it is just looking at our medical visits and our medical visits per user and across the different populations. Respite care is still much higher than the other programs, and even in an average length of stay of 20 days, the medical visits our average visits was a little over 8 visits for medical respite care. So again, tying it back to the triple aim, it's just trying to reinforce the importance of continuity of care with a medical PCP. And then another one of our exits, and this has changed over time, but this is what happens to patients when they leave our respite program. And one of our goals is really to help to exit them to stable housing. That gets harder and harder every year. In our community, we've actually lost affordable housing. So some of our outcomes have changed over time, and some of that has been dependent on some of our funders. When we started our program, we were funded by our local continuum of care, which is a program or sort of a coalition determined, it's a HUD term that sponsors some of our decision making as a community on where we spend not only HUD, but in our community, it's local, state, community, and state and federal dollars. So we originally were receiving some local dollars from our county to help with the leasing costs and the meals, and so we were really focused on our exits from housing. And at the time, we had more affordable housing, so we were looking at our housing exits, and we were, back in 2010, able to exit almost 90 or over 90% of them into stable housing. Last year, it was much less than that. We've lost housing. We've put more of our resources locally into emergency services. So you can see here, almost 70% when we exited them went back to street or to a local encampment. So we would like to have kept them longer, but again, once we solve their acute issue, then we do try to exit them from the respite program because we have more people that need to come into the respite program. And then this is a chart that shows the average charge for a hospital stay in Yakima County for a couple of conditions, one being depression and one for rehab, and it compares it to our average cost of medical respite care. And so we pull this information from our State Hospital Association to be able to show the comparisons that we can show our hospital, our funders, our managed care payers, to show the cost effectiveness. And our goal obviously is when we can safely provide quality care for our patients needing medical oversight, we make a huge dent in the public costs associated with hospital utilization. And we've been able to show this year after year. We, if you look at the respite program, this doesn't, because of the way our program is modeled, we don't include our primary care costs in this, but we could. And it would increase the average daily cost by about $250 a day, and the average patient cost a little more than $2,000 for the average charge per patient. So still, it's very cost effective. And then finally, I would say we also have exit surveys that we use when patients leave. We've created a SurveyMonkey tool that helps them. We have them complete in terms of measuring patient experience, and it's very positive in terms of what our patients say about the support that they receive. And just kind of tying this up, I would say that using the triple aim as our framework, I think we've been able to demonstrate some meaningful improvements in the outcomes here related to access, patient experience, and cost. So with that, I think that is my summary. So Barbara, I think next is Central City Concern.
And I think we're going to Dr. Munson in Boston next.
Great.
Okay.
Thanks, Rhonda, and thanks everyone for joining today. And as Barbara said, taking some time out of your afternoon to join this webinar. So I wanted to just give a pretty high-level overview of what our care model is like in Boston, and then dive into a few quality metrics. But I'm really mostly looking forward to the discussion time kind of later on in our time together. So our program in Boston has been around for a long time. We're in our almost our 35th year of operating medical respite. We started as 20 beds inside one of the shelters in the city, which was part of the original charter of our larger Healthcare for the Homeless program. And really, I think, matured and grew up during the AIDS crisis in the 80s and 90s, where we sort of had to figure out how to take care of a number of really sick folks who needed intermediate care. And as hospital stays grew shorter and shorter, we sort of have stepped in to fill the gap, as many others have across the country as well. I should say, just by means of framing, that our medical respite program is just part of our larger community health center that is Boston Healthcare for the Homeless program, where we have a fairly disseminated model of about 40 different clinical sites across the city of Boston, basically in every place where homeless men and women spend their time. And medical respite is just a part of that. So we've grown from that 20-bed program to now 124 total beds in 2 standalone programs, the Barbara McGinnis House and then the Stacy Kirkpatrick House, which I'll talk about as a step-down program, which is a few years old. And something that I think is important context in terms of what's unique about our practice here in Massachusetts, which has really facilitated a lot of what we've been able to do, are 2 things that I just wanted to call out at the beginning. Was that we had early Medicaid expansion in Massachusetts, really going back to like the mid-90s or so. In sort of what the many folks are sort of familiar with what became the basis for the Affordable Care Act. Was put into place in Massachusetts in the 1990s. And then through some advocacy that our program was able to do with state government in Massachusetts, Massachusetts Medicaid recognizes our program as a billable model of care. So we can bill for the medical visits and the medical respite type visits that happen in our program, and all of the managed Medicaid programs and accountable care organizations have kind of fallen in line behind Mass Health, which have allowed us to provide the service. So that's a unique thing that's been going on in Massachusetts and has allowed us to build a fairly robust model. So let me talk kind of briefly about our 2 programs just to give you an overview. The McGinnis House is our older program, our sort of flagship respite program. We have 104 beds. We're in a standalone facility here in the south end of Boston, across the street from Boston Medical Center. We have 24/7 nursing care and nursing aid care. We're actually, our model of care is that the nurses hold the medications for patients and actually administer the medications for patients, which allows us to do a lot of relatively complex medical care. The patients who are admitted here see a nurse practitioner or a physician's assistant every day that they're here, including on weekends and holidays, and that provider can do everything from change medications to order labs to do wound care, a wide variety of clinical things, making assessments on different conditions. And this is certainly an area of growth for us, but we've tried to integrate case management and behavioral health care into our team-based model here, in which we have case managers assigned to each of the teams and social workers for each of the floors. And we've layered on psychiatry into that model as well, where folks are available to see patients who may need a medication adjustment. Then in terms of our level of care, well, folks have to be independent with their activities of daily living to be here, and they have to be homeless. We're able to sort of do a lot of fairly medically intensive services that don't quite meet the level of hospital. But we're able to provide detox from alcohol, opioids, and sedatives. Sedative and opioid use disorders have become particularly prevalent amongst homeless men and women in Boston over the past 5 years. We do manage IV antibiotics through usually through PICC lines, not peripheral lines, but PICC lines or mid lines. We do a lot of wound care and management of decompensated chronic diseases. And then sort of 2 relative niche practices for us are perioperative care, which I'm sure others are doing as well, where we're sort of facilitating procedures and surgeries for folks around Boston, providing pain management and other sort of perioperative needs. And then we do end-of-life care here as well, where we serve in a hospice role for folks that don't have any other place to die. We can provide that intensive round-the-clock hospice-level service to have them die with us. But a big bulk of our practice, though, is managing decompensated chronic disease, diabetes, heart failure, COPD, infections, those sorts of things, sequelae from substance use disorder that come in either from hospital or directly from our shelter-based clinics or from the street. Just in terms of some basic statistics for us, we have a pretty high volume where we do about 2,400 or so admissions every year. As I'm sure some of you who are in medical respite have folks that come back to your program after they leave, and we certainly folks that are chronically very sick in Boston and living in shelter are frequent users of our respite program. We have a relatively short length of stay on average, and it's been that way for a number of years, about 2 weeks. And then most folks, and this could be a whole other webinar just around access to housing in Boston. The housing stock is really, there really isn't much housing stock, and folks wait a long time with vouchers and things like that. So we do discharge most people back to shelter, and we rely on that network of shelter-based clinics that I mentioned before, and that's all integrated in one electronic medical record, and many of the same providers that work in our respite program also work in our shelter-based clinics. Just some, for the patients, they must be independent with their activities of daily living. They have to have kind of a stable clinical trajectory. We're not good at doing rapid diagnostics and things like that here at McGinnis House. And then one of the things that comes up, and I'm sure folks have this too, is just patients have to be kind of able to be in a bit of a structured setting. We don't allow folks to come and go here. Most of our rooms are multiple folks in one room, so some people don't do as well in that setting. We try to accommodate folks, but to have some rules within the program. Kirkpatrick House is a step-down program for us. We opened in 2016, sort of a level of care between McGinnis House and the shelter. So we have 24/7 case management-like support there, but only about 14 hours a day of nursing support with 12 hours a week of providers. So the patients are seen, instead of they're seen every day at McGinnis House, they're seen once a week at Kirkpatrick House. The patients are more independent there, both with their ADLs, and they're sort of more independent with their care plan. And they self-administer their medications with assistance. It's ended up for us to be some of the folks that are chronically very sick and just can't really be in shelter. We've put a chunk of them over at Kirkpatrick House while we wait for sort of more longer-term plans to develop. And then with respect to the quality metrics that we measure, with respect to the triple aim, and I did want to sort of tease out the difference between some of the external quality metrics that you might look at versus internal quality metrics. And often with payers, you're looking for external, but there's a whole process improvement thing, which I think is really important in terms of making sure that you're providing the best care that you can and getting better as a practice. So. And then a bit of background for that is that, health reform Massachusetts is really experimenting with a lot of different types of healthcare reform, and the newest kid on the block is this accountable care organization, where basically they've tried to get the providers to have some skin in the game in terms of sharing the risk of high cost and complex patients. So our Healthcare for the Homeless program joined the accountable care organization that was started by Boston Medical Center in 2018. And that has led to us having a much closer relationship with that particular payer. So I'll switch and talk about some of the internal metrics that we follow here. So we look at medication errors per day in terms of we're passing medications to patients on a daily basis, and we track the number of errors that occur as a point of that. We review them monthly. And discuss and try to get better around that. We've moved to an electronic medication administration record, which has very much helped that. And then we also track falls per day and total falls per month that have result in an injury. And we've tried to really ramp up our process around preventing and addressing folks that are particularly at high risk. One other thing that I didn't put on here is we also do the patient satisfaction surveys for patients that are specifically in respite. We've tried to adapt the satisfaction survey that exists to ask some respite-specific questions to get at what are folks' experience. And then for external metrics, really it's been over the past, I would say, 9 months that has been the first time that a payer has really closely looked at some of our metrics, which have mostly been around hospital revisit and readmission. So, what's happening to patients if they come to McGinnis House from Boston Medical Center? Do they go back to BMC within 30 days? If so, why? Are they admitted? Did they just go to the emergency room? And what does that look like in terms of how does McGinnis House influence the trajectory of care after discharge? Thankfully, that's been favorable for us so far in terms of looking at folks that have been referred and not gotten into our program versus referred to and have gotten in. But one thing we haven't quite looked at yet is how we impact the total cost of care after discharge. That's I think probably something that's ongoing. And that's it for me. I think that's my last slide. So I'll turn it over to the folks out in Oregon.
Awesome. Hello. Thank you, everyone, for participating in this webinar. It's myself, Jessica, and Jordan, our program manager. And
hello.
I'll tee Jordan up by starting off with talking about our program as it's currently set up. It's going to go through some changes in the very near future, and he can speak a little more to that along with some of our metrics and data. So we're located in Portland, as Dave indicated. We're in Oregon. We run an intensive trauma-informed and person-centered intensive case management program that includes daily client contact. We do rounds every morning to check in on our folks. Our folks are right now currently in the state in a different building than we are. So we're just a few blocks away from them. We're co-located in the same building as our clinic, our FQHC. We have about 31 beds, and they're single-room occupancies, and we connect folks or give the opportunity to our participants to establish primary care over at the Old Town Clinic, which is a few blocks away, as I said before. We really strive for, and I think pride ourselves on the work that we do around trying to secure transitional housing for folks at the end of their stay with us. We really work on attending to the social determinants of health, and I think this is done best by this team that we have, and I'm just trying to make sure that I can get over to the next screen. There we go. So as indicated before, we really want to look at connecting people over to primary care at the Old Town Clinic, or really wherever else they're interested in establishing. They might be already coming in established with a provider, and so we want to continue to bolster those relationships. We try to make sure that people are engaged in their care, and I think something that was noted earlier, we're talking about metrics around how many people have access to health care coverage, and it's so important to also track how many people are actually accessing health care. And I think one of the big pushes of our program, or the things that we really hope to have people get out of the program, is establishing a relationship or continuing to build a relationship where it's already established so they can continue on receiving care. And sometimes that might be at Old Town Clinic, and sometimes that's elsewhere. We work on transition planning really the moment that we meet them at the hospital. So this is prior to their intake in the program, is getting an idea for what the work is going to look like. We do that through a basic biopsychosocial and kind of a resource list survey that we go through with them to have a sense for what they're interested in and what we might be able to partner with them in while they're at their program. I think as mentioned before through the other two presentations on their programs, we're working with a highly complex population. I wouldn't really say that they're complex. I would say the circumstances that they're experiencing are, and with that means we have to engage multiple systems and a whole ton of different providers, and I think we have a really skilled staff who are able to do that complex care coordination that's needed, not only with within our healthcare system, but within treatment, employment, housing, and other benefit systems. And we really seek to follow the lead of the client, to offer options that are really tailored to what they have indicated is most important to them. And we really want to help bolster relationships even within our own program and have a sense of community amongst participants as well as the staff. I mean, we often act as pseudo-family, to the program participants. We're coming in with a lot of social isolation, even though they might have a crew that they run with out on the street, there's separation from them. And so there's something to be said about being able to get to that in the program, is having a sense of belonging and social connection through the daily contact in rounds and other encounters we have with them as well. Maybe move to the next slide. So things to know. So as you can see in that picture there, that is our Blackburn Center building. Jordan will talk a little bit more about that, but we're going to be moving into that building in about 3 weeks. With that change, we're going to be going into a 24/7 case management model. Right now, we're normal business hours, Monday through Sunday, really, 7 days a week. That includes a variety of different backgrounds and experiences of our staff. Some folks are coming in with lived experience and some training and background in human services. We have other staff who are credentialed as EMTs. We have social workers on our team. We have myself, who's a licensed clinical social worker and an alcohol and drug counselor. We have a nurse who is with us 4 days a week right now, and soon we'll be augmenting her hours with the transition to the Blackburn building. We have a unique person on our team who is minding the housing and transition plans of our participants. We have logistics staff who is really looking over some of the operational and room type and food-related work that occurs with the work that we're engaged in with our participants. We'll soon have environmental services staff, janitorial staff, where we haven't had it before, and that'll be specifically within our program. This has often fallen outside of our program, and it's been in partnership with other programs within our agency. And we'll also have security, which is new to us, and will be interesting to navigate and kind of negotiate different crisis scenarios that might come up with them, and where they might be able to prove to be really helpful to us in a way that we haven't had access to in the past. Let me see here, next one. And I'm going to go ahead and pass you guys off along to Jordan, who's going to take you back in history a little bit.
All right, and I know that we only have a couple minutes until the next section of the webinar, so I'm going to quickly guide us through. I just wanted to start at the beginning for just a second to let you all know kind of where we came from and how we arrived at where we are now. We started in 2005, and it started as a partnership between our organization, which operated housing, residential housing in our downtown core, and through taking over a clinic downtown called the Old Town Clinic, which we operate now, we forged a relationship with a local teaching hospital called Oregon Health and Sciences University. And through that, we quickly started working on the idea of how to transition what were then called high utilizers into more safe, secure, and supportive settings. So we decided, hey, we've got this housing stock, let's apply it to people discharging from the hospital with ongoing care needs. So it started with just a few beds and one hospital, and quickly moved on to incorporate really all of the other hospital systems within Portland and all of the managed care organizations that came along with Medicaid expansion in Portland. So that's kind of what brought us to this new point of expansion, with continuing influx of migrants into the Portland area. We are continuing to see increases in demand, increases in rates of homelessness, and in overall numbers of homelessness. So we are continuing to struggle to meet the needs, and in doing so, we have quickly moved on to recognizing that we need to build a new facility. And this Blackburn Center, which Jessica already described in part, is not just a respite facility. It is a fully integrated place with a bunch of different services at it. And we are really aiming to integrate all of those services from the start rather than reactively figure out how it all fits together later. So this new building is going to have 51 respite care beds and have full integration with the clinic downstairs. So instead of bringing our patients several blocks over to a clinic, figuring out all the mechanics, we're literally just taking them down one floor on the elevator, which is going to be great, while we continue to actually operate the respite program as its own independent but closely affiliated program to primary care. In terms of metrics, we have tracked three things from the very start, and they are reflective of kind of the unique kind of hybrid nature of what our program model is. We have tracked the percentage of participants placed in transitional or permanent housing at exit from the program. We've tracked the percentage who have resolved their acute medical issue, and the percentage of folks who have a medical home at exit. This is really reflective of the fact that we are operating an independent housing setting with ties to primary care, and in which we have tried to push forth the value of medium and longer term placements for folks, really working on social determinants of health in addition to the notion of recuperation from an acute medical condition. So as we have added payers and partners, we have really pushed these three things as centerpieces of what we do and why we do it. Those are the formal measures that we have in our contracts, in contracts with the City of Portland and with hospital partners. Over the years, we have really kind of moved away from the necessity for those in the same way that they were necessary at the beginning, and tried to use metrics more as a way of learning about what our strengths and weaknesses are, and learning about what the impact on cost is. So we continue to get more sophisticated in our ability to understand the impact on hospitalization. So the final slide before we make our way to the next one. This is, on the left, kind of the formal metrics. Over 70% of folks coming through the program have resolved their acute medical condition. 95% of folks are established with primary care upon exit, and over 60% transition into some form of permanent or stable transitional housing. And then on the right, this is a new tool that we worked on this year that makes use of some data sharing networks within our Northwest Hospital data systems, so that we're actually looking at care. We're measuring the impact of our program on our patient utilization of any of the Northwest hospitals in 1 year after their enrollment with us. So that inflection point in the middle of the chart is a ramp up to a significant catalyzing hospitalization, and then after that spike ends, that's where our program's intervention began. So this is really compelling for us to use and show to our partners to give them a sense of the real world implication of the application of our program. The data is not perfect, but it's really meaningful. And so we're using this to continue to learn. And with that, I'll stop and pass it on.
Great. Thank you all. I really appreciate learning more about your programs and the measures that you're using to evaluate your effectiveness and your patient outcomes. Just want to take a few minutes to hit the highlights of the policy brief that we published. And again, for those who missed the beginning, in the resource box at the bottom under policy brief is the policy brief that we are referencing. And when we talk about the IHI triple aim framework for health, we're referring to the Institute for Health Improvement. This is a nonprofit organization. They're fantastic. They're cultivating innovative concepts for how to improve patient care and implement programs and get those ideas in action. And as the name would imply, they're really focused on how do we get better in our healthcare system. And they focus a lot on quality and innovation and partnerships and data and how do we demonstrate getting greater value in our healthcare system. And so just want to hit the three areas of the triple aim of population health, experience of care, and per capita cost. And I'll just talk a little bit about these in a couple of slides. And again, just want to point to also the IHI guide for measuring the triple aim. And so they have put out a white paper. Again, we've put this in the resources box below on what do these measures look like, so some examples, how do you go about measuring these? And this has been the platform for how a lot of larger health systems in the country have framed their own health reform initiatives within their systems. And so what we're just trying to do is align with what the greater healthcare system is doing so that when we're talking with our hospital systems or our insurers or larger systems within our states or communities, we can be speaking the language that's important to them. And so just moving on here, also highlighting mutual interests. And so Rhonda and Dave both mentioned payment reform and how payments are changing to link to outcomes. And Dave even talked about like getting skin in the game at the provider level. And there's a lot of movement around how do we hold everyone in the healthcare system accountable for the outcomes that they're providing. And so the stakeholders that we're talking about, and I had mentioned before, hospitals and health insurers, but we're also talking about Medicaid programs, public health leaders in your community, the people who are specifically looking at what is the health of our community. And everyone's interested in reducing cost. Everyone's interested in getting better in terms of quality. And then that value proposition that we hear a lot about now is what we're trying to align medical respite programs with the work that we're doing, of lowering cost, recognizing social determinants of health. How is it that we've got an intervention that the larger health system needs in order for them to meet their goals, then we align our goals with theirs. And then we're in a strong position to leverage this. Again, we're using data and using our program development to drive that change. And so if we just want to look at the first component of the triple aim, improving population health. So population health can mean a lot of different things to people, but this can be specific to a geographic space where you're looking at maybe the health outcomes of a zip code or a county or a city or something that's defined by boundaries, physical boundaries. Or it can mean looking at specific characteristics of subpopulations. So whether we're looking for disparities based on race or ethnicity, on socioeconomic characteristics, looking just at people with disabilities, or in this example, looking at people who are experiencing homelessness. So how is it that we're being more refined and more sophisticated in how we're documenting where disparities exist, but then also how are we getting better at improving those disparities? And so this particular aim is around 3 areas. It's looking at health outcomes, disease burden, and then behavioral and psychological factors or physiological factors. And so here's just some example outcome measures that actually align with a number that we've already heard from being used through our programs that you might consider, but there's more that are suggested in our policy brief, and there's even more that IHI has at their organization. And I should also mention, if you want to learn more about IHI, they're at ihi.org, and there's a wealth of resources that they have there on quality improvements. The second aim is improving the experience of care. Actually, Dave had mentioned that they're using patient satisfaction scores to look at how their patients are experiencing care and how are we getting feedbacks from the people that we serve so that not only are the services that we're providing aligning with what our clients want and need, but then how do those scores align with how or whether we're getting paid? How do they help our larger healthcare system achieve better patient satisfaction scores on their side? Because patients are happier being in medical respite programs than they are with extended inpatient stays. And this is really also around 6 elements of care here. We want to make sure that the experience of care that a patient is getting is safe, effective, timely, patient-centered, equitable, and efficient. And again, here is just one possible outcome measure that could align with each one of these elements for this particular aim that would be appropriate in a medical respite program. But a lot of this is standard surveys that are used in hospital systems that we can also adapt questions for in our programs. Third area of the triple aim is reducing per capita cost. And now there's a lot of attention that's being given on costs in our system. And we could have a whole separate conversation about costs in the healthcare system. But really a lot of that conversation will center around cost to whom. And so when we think about per capita cost, we think about what are the consumers paying? So a lot of out-of-pocket costs, or what does that look like, again, from a demand for services lens? What does cost look like from health plans or health insurers? What are our managed care partners thinking about when it comes to cost? And then providers like ourselves, our hospitals, the specialist community, everybody's looking at what costs mean to them. So depending on who you're talking to and aligning outcome measures really depends on where the cost is being realized into what community. And so and then you can align that conversation to match their interests. And again, here's just a number of targeted stakeholders that you could have conversations with around cost. And then maybe just, again, an example outcome measure that you might consider that's appropriate for medical respite that would align with each one of those. But these are the kinds of things that all of the hospitals and insurers and these larger systems are looking at now. So how do we get smarter and better at aligning what we're tracking with what they're tracking so we demonstrate our value in that continuum? want to just wrap up again, hopefully what you think is a quick description of the policy brief is what can we do? How are we driving a lot of this into implementation? And so a big part of this is just having the discussions that you need to have with your stakeholders, whether that's your insurer partners, it's your discharge planners at your hospitals, it's with the executives at the hospital, wherever you're able to work to get an audience, talking about what the patients need in your community, both in the hospital system, people who are insured, and all of that, and identifying who's tracking what data elements, what would we be able to align with, where are there gaps in the available data, and how can medical respite programs fill that gap, or could we identify something that we could assist with? Thinking about, like, how do you collect it, how do you report it, and to whom, and what are you trying to leverage with that reporting? And so again, it comes back to gaining greater recognition for the role of medical respite in our communities and getting greater sustainable financing mechanisms. At the same time, being able to demonstrate our value that we're worthy of that recognition and that financing. So thinking about what's the funding needed to support those outcomes that we need. And then if you're not doing respite yet and are trying, or you've got respite and are just really starting to frame out your performance measures, start small and then scale up from there. I think a number of our presenters today talked about how they started small and they just grew from there as they got more experience. And then finally, visiting other programs, seeing what other people are doing, listening to Rhonda and Dave and Jessica and Jordan talk about their programs. We've got a lot of other programs in the country that are doing medical respite. Every program is unique in its own way. It's trying to align with the unique characteristics in its community. And so that's the challenge, right, is figuring out that this isn't going to look the same for everybody. So with that, let's plunge into our panel discussion, which I think is getting more conversational. And so just want to open up by saying, for the 4 folks who are on our panel, how do you see the triple aim framework helping to bolster medical respite programs? And Jordan and Jessica, why don't we start with you in Portland?
Sounds good. I think that from the start we viewed our program as a way of meeting the triple aim, and as we have worked with sort of payers coming in and out of the conversation over the last decade plus, it's been a really helpful introduction to the goals of the program. And I think for me, it's always felt like a really safe way of talking about the goals of the program in a way that includes both work we organizationally want to do as a Healthcare for the Homeless organization, while recognizing that there's all sorts of cost implications for the work that we do, and understanding that there's strategy in that, and understanding that we need to be impactful in that area. And so to have all of the aims put together, including the one we care often most about, the patient experience of care, it's a way of understanding that even if we're talking about cost, that's okay, because we're also going to be talking about the other 2 aims. So we have seen here lots of changeover in both the organizations that we partner with, the actual people in the organizations that we partner with, to set up these transitions of care relationships, but even in the structure of the organizational partners themselves, and which organizations are involved and present at our community discussion about this work. So with that comes all sorts of necessity for ongoing sort of recalibration and reorientation to what we're doing and why. And the triple aim has been a really useful framework for us to re-enter that conversation, often with new people at the table.
Sounds great. And Rhonda or Dave, do you have anything to add to that?
I would just, I would add that I think, medical respite is hard to define sometimes, and it is a type of, it's a model of care that is, as many of you know, sort of struggling to gain legitimacy across the country with different funders and payers. And I think the triple aim provides a really nice framework to show that you are doing the type of value-based care that is happening in other places across the healthcare system, that you're focused on exactly the same things in different ways that other more well-established or more well-recognized models of care are doing. So that's one. And then I think the second thing it helps do is it helps you improve your own practice, so that you're responsive to the needs of your patients or clients, and that you're really providing. It allows you to identify your blind spots potentially, and really focus on the things that you're not, or identify the things that you're not doing well potentially, so that you can get better and provide the best care for those who really need it. Rhonda?
I think you guys have covered it.
Okay, great. How do you think how should brand new respite programs who are just starting out use this information? And then how do you contrast that with where more established programs might benefit from this? And Rhonda, maybe we'll start with you.
So, I think that I think using the outcomes that were suggested, some of those that you went through, is really helpful, particularly for new programs. I know when we started, we really struggled with, number one, just having the ability to find outcomes that we could measure. And that's sort of why we started, we looked at those that related to the triple aim that we were already collecting for other purposes. And I think that really served us well. But also talking to the partners that we needed to have involved and finding out what was important to them. And I think using the framework, and again, to both what Dave and Jordan just talked about, the framework provides a common language. The IHI framework now provides a common language for us and our partners to talk about what's important to them and what's important to us. And I think as we get more developed in our programs, I guess an example that I would use is that we've used a SurveyMonkey exit tool for a survey for our patients for several years, and we put it on an iPad, and we take it to them in respite and have them complete the SurveyMonkey. But the questions, I think, related to the patient experience, I think we want to align better with some of the outcomes that the triple aim framework is looking at. So questions that are specifically gauged more around self-management and patient engagement, because those are so important in terms of, we know, reducing, for example, emergency room use and continuity of care. And so I think about, how can we maybe change some of our things around patient satisfaction and engagement to maybe for some of the work that the triple aim has done, and maybe help us glean some of that. So those were a couple of the examples I thought of.
Dave, Jordan, or Jessica, anything to add there?
Yeah, it's Jessica. The question about, how brand new programs can use the information, I think is compelling for me. And having interactions at the most recent National Healthcare for the Homeless conference with folks that I'm familiar with who are wanting to start the program, it's often individuals who are in shelters who have seen a need to connect somehow these individuals to medical care and being unfamiliar with the landscape. And I think the triple aim, as it stands, I think provides a lot of new language, and a really general understanding of the things that I think healthcare systems, whether we're talking about hospitals or payers or other folks involved, care some about, right? But I don't think it's all of it, and I think the document that was created, the white paper, as well as just the triple aim in general, provide an avenue for a way to think through how they want to step into the work. I think Boston Healthcare for the Homeless, they have a pretty robust medical service that they offer. And our program, while it does have a nurse, and we do a lot of work around linking folks to primary care and making sure that their medical needs are being attended to. We place a heavy amount of our capacity or service to do the work around some of the social determinants and specifically housing-related work to try to deal with some of the recidivism. And so I think in thinking about the triple aim and thinking about new programs, I think it provides a framework. It provides some kind of parameters to think about, what might be important, to pitch this to stakeholders to make that connection to medical care, while recognizing that there are going to be decisions that are going to need to be made by that program themselves along the way about, all the underlying things that might undermine the overall goals of attending to the healthcare part of the work that medical respite attends to. So in a roundabout way, I think I'm saying that it provides some parameters for having a conversation internally for new programs, for what they want to be about, and then figuring out or having shared language, has been said multiple times, to talk to stakeholders about what they're about and what they want to offer as a part of their service.
Anything to add, Dave?
No, the only thing I would say is that I think you can really use this as an established program for process improvement and self-improvement, and we've done that with the fall stuff that I mentioned, where we recognize that we have a problem with falls here. What we were doing to try to mitigate and prevent falls wasn't really working, and we used a lot of this framework to completely revamp that process, and just been on my mind because we launched a whole initiative this week. But I think that's and we've been screening for falls for 20 years, but it's being introspective. This allows you to be introspective regardless of how established your program is, to make your care model better.
So when you are determining what measures to track, especially part of this is medical respite is designed as a short-term intervention. And so a lot of the getting better in diabetes or hypertension or a lot of chronic disease management, that takes a lot more time than medical respite programs generally have. And so I'm curious, how do you determine what measures to track that are appropriate for the short-term nature of medical respite programs? Maybe we'll start with Portland and see what your thoughts are.
I think my first thought is that our population kind of gets to define that for us. In thinking about some of the ways that our program has changed in the last several years that I've been around, I'm seeing that we are taking folks whose illnesses are not only chronic but pretty advanced. And so that has made us look more closely at what are we doing, or what have our services look like, and what is our data showing about those lengths of stays, the outcomes around their health care for folks who are, needing palliative and end-of-life care, which is different than, what medical respite is often intended for. Like we said, the acute conditions that usually are resolvable within a shorter time frame. But maybe Jordan has more to add to that. That's the first thing that's coming up for me.
No, I totally agree with that. And I think, I want to recognize our partners have really looked to us over the years to drive this conversation. And as such, I think that the better we are at having ongoing kind of continuous conversation with our funders about what their pressures are and about what their opportunities are as stakeholders in this form of community work, we've been better positioned to align that with exactly what Jessica brought up, our population's needs. So we're able to kind of tie the idea of how do we provide better care and support to an emerging subpopulation with this idea of how do we do so in a cost-effective way and in a way that shows robust success in terms of health outcomes. Yeah.
Dave or Rhonda?
I love this question. I think it's a really thought-provoking question. It's tricky, and I think something that we've thought a lot about in terms of like how can we best affect chronic diseases when our length of stay is 14 days. The one thing, and I don't know the answer. I will say I love the idea of thinking about using respite to connect people to services or to bring organization to a life that's existing in chaos outside. Thinking about connecting people to primary care, or making sure people who are eligible for SSI are working through that process, or making sure that people's insurance is up to date. All those kinds of things that can be really difficult to take care of outside, I think are interesting and probably reasonable measures to track in addition, I think that meets in the middle of like what your payers want you to track in terms of, hospital readmissions and ED revisits and stuff like that. But anyway, I'll just add that because I think it's hard to impact the chronic diseases in a relatively short period of time.
So, I would say that kind of halfway in between there. I think we sort of have our anchors that we're trying to track, and part of it is to help meet some of the needs of our funders as well as our own. But starting with keeping people out of the emergency rooms, and this starts with our general population. We have access issues in our community as a whole, whether these are people that are housed or people that are not housed. And so I think those will always be measures that we'll want to measure. But when we let people out of our respite program, whether we have housing for them or not, we typically tend to continue case managing them. If they go back to the encampment or the shelter, we continue relationships with them. And so continuing to try to keep them connected to their medical home is one of our goals. And so while it may not be a direct relationship between their A1C being able to go down over a period of time during our average length of stay of 19 days, it's probably not a direct connection to respite. But if we started that engagement in the respite program, which is often where it begins, particularly with our chronically homeless, over time we may show that in our other report outs. So I still think the relationship with primary care is still a very important outcome, and Dave just alluded to it's all those other things that you're able to connect them to in that short period, whether it's SSI or SSDI and health insurance and all those things that we know that make a difference to a person's willingness to get in and to continue the care. And the other piece for me is, even though we're not being very successful, is the housing placement, and it helps us in our community make the point for affordable housing and the continued need for affordable housing, because we can show even people that are this medically fragile, we're not being successful. So even though it's a poor outcome for us, it does help us make the case that we need to help in our community to further the cause for more affordable housing.
Got it. And then I know that when we were talking and planning this call, a number of you talked about the tension between measuring what you really want to measure and then having to create measures specific for your funders, and so that internal, external measures that a couple of you talked about in your briefing. How do you resolve the tension in that dynamic? And Dave, why don't we start with you?
Yeah, I think that's. I think a couple of people have alluded to, having close relationships with some of your funders, and I think that has worked for us. In terms of trying to meet in the middle on some things. And recognizing, and I think recognizing and acknowledging that the things that the funders care about are important, and it's good to keep people out of the emergency room, and they shouldn't, if they come to your program, they shouldn't go back to the hospital, for a little while in case something happens, unless something happens. But then also you have things that you're going to understand specifically because you're a homeless service provider, and so just trying to meet in the middle on that, I think through close relationships. But I don't know if others have a more articulate thought than what that was.
Others have another thought?
Well, this is Rhonda. I think one of the things in recent discussions is that I think that one of the things we could be doing better is asking the funders to help us track things. Particularly with the managed care organizations, we have been certainly trying to provide them with information to justify why they should continue funding us. But I think that oftentimes they have information that could be helpful to us. The example that we've talked about recently is that if they are supporting us, they have information about other costs that the individuals are being reimbursed for, that other units are being reimbursed for to support our patients that we don't have. And I think that would be really helpful information to us so that they could maybe be providing us some information about the patients that we share, the members that we share in terms of costs and utilization. But Dave, I think just sort of said this, but our relationships with our funders are typically right now all based on relationships. And I think one of the challenges is to try to institutionalize that a little bit better so that it's more based on regulation or statute and not necessarily based on relationships.
Got it. Jordan and Jessica, anything new to add to what Dave and Rhonda shared?
No, I think we've covered it from my perspective.
Yeah. So I know we've just got like maybe 10 more minutes or so for our discussion before we go into question and answer. But so on these last few here, let's just, one of the things is, how do you determine when your measures need to change? And it's a fairly straightforward question, but one that people don't think about headed into this. Rhonda, what's your process for thinking about that?
Right now, again, we have been pretty stable in terms of our measures. Looking at our interest is to try to have our measures and our outcomes, other than the housing issue, be at least equal to or better than our general population. And so we have not really steered too far away from that. So I don't really have anything new to offer on that one.
Okay. Others?
I'll just say we have a program-wide at the ACHP quality program, and that program once a year checks in with each of the sites, and of which we are a site, around quality metrics that the sites are tracking, and gives us an opportunity to review the ones we have tracked for the previous year and think about if we want to add any new ones for the upcoming year. So that's just an iterative thing that happens every year.
And then I'm thinking, too, as we kind of look forward in the next question here, for those who are on the call who are from hospital systems or working for managed care or other types of insurers, how would you advise them to use this information? And why don't we start with Portland. Jessica or Jordan, do you have thoughts on that?
I mean, I would encourage them to read the policy brief. I think, sorry, I dropped my coffee on a keyboard, but I think it's just really useful calibration of the discussion. And I think that as we continue to have conversations with our funding partners and other stakeholders, we find ourselves in periods of time where we recognize that our conversations about community need or even financial pressures don't necessarily match up well with what we've tracked historically or what we think we're supposed to be focusing on. I would suggest that it's used as sort of a theoretical menu of perhaps new ideas about what could be actually useful to focus our attention and resources on, rather than some things that we may be doing just because we're doing them anyway and we always have. I think it's really useful to consider lots of different types of measures and the different sorts of value that the work that supports those measures brings to our work. And that's not often where programs start, nor where services start. But I think that can be a really useful guide for where to take people.
Rhonda or Dave, anything to add to that?
I would just say, I would just reiterate what I said earlier. I think it provides a common language, and I think that just strengthens the argument. Whether it's hospitals or insurance, I think the framework itself, really provides the outcomes that really help bring the discussion to a common place.
Yep, I agree exactly with that.
Got it. Okay, so last question, maybe a lightning round since we're coming down on time. As you look out over the next 5 years with the changes that you see going on now, how do you see medical respite programs fitting into health reform efforts, especially given the increased focus on data and value-based payments? And Dave, why don't we start with you in Boston, just your thoughts on what that looks like coming up.
So yeah, I think we're essential to this as medical respite providers, because I think we fit a perfect niche in terms of that we figured out a lower cost model of care that is inherently patient-centered, and that we really know our patients really well in ways that other parts of the healthcare system don't. So I see us really fitting in, and I think it's essential that we figure out how to get sustainable, regular funding for our programs across the country. As Medicaid, kind of gradually expands, we should be right there with Medicaid expanding in different states, because we fit right in ways to lower cost and provide, value-based care for this really complex patient population.
Okay. Rhonda or Jessica Jordan?
Yeah, I would just say, in Washington State, part of our Medicaid waiver had there were 3 initiatives, but one of them, the first was our accountable communities of health, and that's really a collective impact model for communities, and ours had a fair amount of local dollars that we were able to apply for from a population health standpoint, and that allowed us, that's how we're able to expand our medical respite program. And so I think those are Medicaid dollars that are really looking at population health at a community level, and I think that's just one creative way that states could look at that. And then the other was an initiative around long-term services and supports, and that's really looking at ways that allow people to age in place in their homes. And, as we're talking about, the folks that we're working with are people that typically don't have homes. But it's another way that Medicaid is looking at lowering the cost of care for people. And I think medical respite is the same concept as the long-term services and supports. And I think, anything that we can do that makes medical respite reimbursable as part of our state plan and not just based on relationships is going to further our efforts and our cause.
I think I would add, Jessica in Portland, I would add thinking about maybe the changing face of medical respite to include, higher acuity mental health, concerns that people might be dealing with, as well as end-of-life care. I think in our state we're seeing that there is a push for creation of, billing codes to be able to use facilitate palliative care programs at a community level that haven't existed. And that's work that we've been trying to figure out how do we sustainably fund. And so, we're working out how we can be a part of that effort to make those, reforms pass through so that we can make use of it and be able to have the ability to offer that service for a population we're already serving right now, but not in a way that's going to be sustainable and not with the extent of support that we need in place to fully support an individual in our program with those type of needs, as well as folks who are dealing with more serious mental health issues who, I think in a lot of medical respite settings right now, are likely ruled out, and not brought into their programs. How do we, have our hand in being able to access funding through Medicaid or through the state, through mental health programs to be able to have those folks who have those same needs of having a medical issue, but also having the complexity of mental health issues going on in settings like ours. And so I think for us, we're already stepping into some of that work, hopefully rolling out mental health RCP, recuperative care program, this summer, depending on what some of these conversations are on funding at a higher level, with the state and some of the changing landscape of who's handling those funds, is working itself out. But those are some things that we think about for the upcoming years.
Okay, so I really appreciate just your sharing your thoughts, your expertise in the programs that you're running. At this point, we'll open it up to some audience discussion. As we've been talking, folks have been sharing some questions. For those who are still on the call, if you've got questions that you want to plug in, please do. But let's start with a group of questions have come in about you sharing either the questionnaires that you give with your patients or the data collection mechanisms that you use or the exit interview questions. All of those have kind of been in the same nature, that people really want to just see what others are doing. And I'm curious, a number of you mentioned using iPads, SurveyMonkey, and other mechanisms to get patient data. And I'm curious if you wanted just to talk a little bit about the mechanisms that you use to get this information from your patients.
We use SurveyMonkey. We have a paper copy that I'd be happy to forward to you to send out if you'd like.
Oh, great.
And I guess we have sort of two mechanisms. One, we have I didn't mention this, but we have a real-time almost like sort of grievance and patient suggestion process here, which is a paper form where if patients have a suggestion about something that they think should, we review those monthly. That's just a pretty straightforward grievance. And then we do use the patient satisfaction survey, which we have some volunteers administer on an iPad, and we can share the survey with folks who might be interested.
Got it. And Jesse and Jordan, did you have anything you wanted to add to that? Just making sure.
Nothing to add.
Okay. A few other questions have come in some around financing, and a number of you talked about Medicaid, and I do think it's important to note that all of you are operating in states that have expanded Medicaid under the Affordable Care Act. And so I think that there's different funding issues and certainly coverage issues for those programs operating in states that have not yet expanded Medicaid. But I'm curious if you want to, or could you just talk with the role of Medicaid in getting the Medicaid to recognize your services. And Dave, let's start with you just because you've talked specifically about medical respite being recognized in your state's Medicaid program.
Yeah, that existed before my time, where I've been with the organization for about 7 years, and that really goes back about 20 years, where through really some advocacy with the state government, we were able to get folks to see our program as a billable service, and then we've just kind of been folded in ever since. And most pretty consistently, as there's been payment reform experiments in Massachusetts, which have led to managed Medicaid programs, they've pretty much all fallen in line. With that, we had one experience where a managed Medicaid program did not pay for respite for a while, but again, it was, it's funny what Rhonda said about relationships, because then we hosted them over here and we walked them around and we showed them some data, but mostly it was about walking them around and showing them this place and what we're able to do, and then they kind of turned around and build for us. What's going on with BMC and the Boston Medical Center ACO has been different in that we are sharing a lot more data, and they're tracking the data much more closely than any payer we've ever had. And so I'm not sure where that's going to go, but it's been interesting to have them really on a monthly basis report back out some of these revisit metrics. So we'll see.
Others who get Medicaid funding?
Yes. Sorry, go.
I'm sorry, I was just going to say that, part of this, I think, also depends on your model. For example, we don't have a provider, a nurse practitioner, or doctor that's part of our respite program. So our reimbursement is really based around care coordination because our primary provider at the respite program is a nurse. And so our negotiation with our Medicaid programs is we get reimbursed for care coordination, and in some cases it's a daily rate, and in some cases it's a case rate. But for the primary care, we actually take the patients to the clinic next door, which we get our regular primary care payments as an EF2HC would. So depending on what kind of model you're setting up, will also determine what you're negotiating with the Medicaid program.
And this is Jordan. Our environment is similar to Rhonda's. The Medicaid money that we are able to utilize for respite care at the level that it is largely because of the Oregon waiver that we have in place that allows for a significant amount of managed care spending on flexible services that includes and overlaps with care coordination. So that is our bread and butter in terms of our partners' ability to invest in this work.
We have time, I think, for one more question here. So what mechanisms have you used to measure cost savings for the reduction in inpatient stays and then an increase in primary care outpatient visits? And I think a couple of you talked to measuring the number of visits that you track, but just can you maybe expand upon how you measure cost savings there?
Well, this is Rhonda, and we measure the visits, and that's easy from a primary care standpoint. I think this is the area where I said this is where we could actually use some help from our managed care organizations. We could show the average cost that a hospital goes through and an average cost that we have, but the managed care organizations that are paying us could actually help us a lot by showing us the cost comparisons of our patients that they're paying us for the care coordination component for compared to maybe other patients that we've identified that are members of theirs that are homeless that are not receiving the same level of services. They have that information, and they have it from all of the other services the patients are using. So that's one that is right now eluding us, but we've seen that others are able to get it. So I think that would be a great thing for us that we're going to be working toward in the near future.
Anyone have anything to add there?
No, I'll just to add that we have had the same. It's really difficult to get the cost data because it has to come from the payer generally. So that's that's one of the things that has always eluded us a little bit. Yeah.
And likewise here in Portland, though we, as I've mentioned, have worked on being able to demonstrate hospital utilization data detached from cost data, and have done so successfully as some form of a proxy for cost data. But similarly, we are working with our largest payer here on taking next steps in terms of identifying exactly what we really want to look at in terms of cost, considering sort of the subpopulations we want to be focusing on.
Barbara, I think I would just add that I believe that on the council's website under the publications, there are some publications that show some research that's been done from, and I think it's been from the Boston program. I think there are others that have done some studies about cost savings of respite programs.
And I think that's an excellent transition, thank you, Rhonda, to our additional resources that we have available at the council. We've got the website that's listed here. There are so much materials that we have, the standards for programs, a directory of where programs that we're aware of are in the country, a toolkit that's got a lot of what we've talked about here in the research, and so what Rhonda had just referenced. A lot circles around the Respite Care Providers Network, and Dave and Rhonda and Jessica and Jordan are all participating in this along with many of their colleagues around the country to provide more capacity and technical assistance for bringing these programs up, also policy briefs on financing and some other things. So please check out our resources there. I really also would just like to do a huge shout out and thank you to all of our presenters today, Rhonda, Dave, Jessica, Jordan, you guys are really great. You're subject matter experts in this field. Thank you for sharing with us what your programs are doing around this issue. And really want to appreciate everybody that came today for joining this webinar to talk about medical respite and the triple aim framework. If you missed the beginning of our discussion, yes, you will get the slides and the recording that are emailed directly to you, and it'll also be on our website. And then as soon as this webinar closes out, which will be any second now, you will get an online survey that will pop up where you can evaluate this, particularly to the learning objectives we've talked about earlier. But please provide any feedback or comments to us at the Council that you would like to inform our decisions on our training and technical assistance.